And so we are extremely honored to have Dr. Ullman join us this afternoon. Thank you.
Thank you. Thanks, Anita. I want to thank Anita and Scott, who was sitting there but ducked out, and those who were part of this IBD Horizons group, and particularly Paul Strunk, as well as our many sponsors for bringing us all here where we love being on a Saturday, which is in a conference room. I do truly, I say that tongue-in-cheek, obviously, but I very much do appreciate the notion that you've all elected to spend the better part of your Saturday here in a conference room to learn something, and hopefully I'll contribute and not detract from that goal. It is very nice to be here close to The Ohio State University. Anita did not mention, it's not important, I did my residency at the New York Hospital, so I get this whole article nonsense business. We're going to talk a little bit about chromoendoscopy, and based on the answers, it looks like I don't have much to do, and I probably won't succeed in my desire to educate folks, because there were, at least for that first answer, you kind of get it. By show of hands here, who regularly does endoscopy on IBD patients? And just put your hand up in the air. Okay. Keep hands up in the air if you routinely use chromoendoscopy on your IBD patients. Okay. And that's not a bad thing. And when we're done today, you're going to feel good about that, not bad. And I think that, that sort of is the large message, that what we're doing and what we do as endoscopists is actually what we already do, and what we have been doing for years is already pretty good. If you get a good pathologist and you take your time doing these and spend a lot of time looking at the mucosa, not so much to make sure that there are no large ulcers as part of your CDEIS, but really as a function of trying to detect dysplasia with your eyes, you may not need chromo as much as some experts would have you believe. I forgot to get my disclosures, which is getting shorter, but hopefully to get longer in the future. Cancer surveillance in colitis is a lot like cancer surveillance in almost any chronic condition that is associated with an increased risk for cancer of that organ. Whether we're talking about COPD patients, chronic pancreatitis patients, patients who get many sunburns and basal cell carcinomas, for melanoma down the road, right? We know our high-risk patients, and so what we do is those with a high-risk inflammatory condition, we initiate screening and surveillance after there's been some element of time, because time is really the important factor here in the multi-hit hypotheses toward neoplasia and carcinoma development. And then after we have found that intermediate morphologic change, and in our case what we're looking for are polyps, we then intervene either with a polypectomy or bringing in our surgical colleagues to do a colectomy to avoid that progression from dysplasia to cancer. And what we're really trying to do best of all is impede or eliminate that step of cancer going to cancer-related death. And it's really those two steps of starting, being really good at maintaining those intervals, and being really effective at bringing your patients back, having a good recall system, all the things that you don't see much in the medical literature because it's not as sexy as coming up with a new way to detect dysplasia, but those are the things that are really important, and probably doing good polypectomy technique in our patients, probably way more important than whether or not you use blue spray dye or any adjunct to our current systems. So the purpose of a surveillance colonoscopy in IBD, as it is in sporadic colorectal cancer, which this whole business is starting to look a whole lot like, is to clear the colon, to identify and remove all neoplasia. And to do that, what we really want to do is have great visual information in front of us, perhaps as best as we can. And there's really, limited added value to the whole business of taking these non-targeted biopsies. As you may know, the whole business of non-targeted biopsies started after in the late 1960s at St. Mark's in the UK, when the pathologists Morrison and Pang found out that this precancerous change, and they hadn't called it dysplasia yet, but precancerous changes in blind random biopsies of the rectum were associated with colon or rectal cancer elsewhere. Not that there was necessarily cancer in those biopsies or that they indicated that something really imminent was happening, but that if they found it, it was associated with cancer elsewhere. And then our sort of poor initial efforts, radical, but sort of poor relative to where we are now in terms of optics, with fiber optic scopes, started to happen in the 1970s, and then that gradually evolved into the video chip technology that we have now, and our ability to really see and detect things on the colorectal surface that we really don't want our patients to have. And sometimes part of the issue is how much is the active inflammation of colitis interfering with our ability to so define them when we see them, because sometimes we don't know when we see them. And it turns out that there's been this great evolution over time, right? So in the 1970s and in the 1980s, and maybe even into the early 1990s, we used to think that most dysplasia in IBD was invisible, that we couldn't see it. But in reality, it turns out that most dysplasia that we see in the modern sort of Olympus 150 and greater, there really were no 150, so it was really 160 and greater scopes, because again, the 140s are too old school, but the 160s and greater, it's a different world. And now that we have these high-def screens that we can look into, we can really see things a whole lot better. And it turns out that most dysplasia really is visible. And so these old terms that we used to have, we can kind of throw out. DALM was really was a horrible term, this dysplasia-associated lesion or mass that came out in the early 1980s from a publication out of the University of Chicago. Most of those patients were referred in because they had large masses, and it turns out if you biopsy them, maybe you only found dysplasia because you caught the wrong part of the lesion. You resected those patients. Most of them were referred for resection. So it was this great surgical series of patients referred in who had no evidence or no clear-cut evidence of carcinoma prior to their surgery, but they were being referred into surgery because someone feared that there was a carcinoma present at the time. And so DALM is sort of a dead term. Try not to use it anymore. What we really want to do is define lesions as either being visible or not visible. And in a similar term to the Paris classification in sporadic colorectal adenomas, things are either flat or raised. And flat means that they are visible, but their width is much greater than their height in a Paris sense. And they may or may not have a raised element or even a depressed element that's there, but you can see them. And so we want to think visible, not visible, flat, raised, and resectable or not resectable. And that last term is a little tricky because what may be resectable to you, I may be too chicken to want to remove it. Or I'm not comfortable doing piecemeal in something so large in a patient with IBD, but you are comfortable in doing that. And there are no guidelines for any of this. There are no real definitions either to help us out of that jam. But we know it when we see it, much like Potter Stewart's famed definition of pornography by the U.S. Supreme Court, right? I don't know it, I can't define it, but I know it when I see it. It turns out that there's great sensitivity that's out there with what we have now. That sensitivity is improving for detecting dysplasia. And ACG surveillance guidelines that are really up for a bit of a renewal, it's been a number of years here, states that for patients with left-sided or pan-ulcerative colitis with 8 years or more of disease should undergo surveillance, the exception being patients with PSC and UC. In those patients, you start immediately. And the technique actually does call for these random biopsies because it's really just a holdover from the past. And we really hadn't had enough time in 2010 to have gone about and taken a look at how how effective random versus non-random was. We still haven't gotten there, and the technique, or rather the optics, as I've mentioned, have really drastically improved over the last decade. You're supposed to take 33 of these non-targeted or random biopsies. throughout the colon, with a focus on things that are raised or look a little funky, whether we call those items nodules, masses, or strictures. And those are just words. They're not really operationalized just yet. And we do it every 6 months to every 2 years. Really every 1 to 2 years, I think, is how most folks are doing it. And then the outcome is then reviewed by a pathologist, and the follow-up interval and or recommendation for surgery is followed based on what the pathologist sees. So in a way, we're just messenger boys and girls to our pathology colleagues, who probably get more per colonoscopy than we do, but we can discuss that on another Saturday, not today. The British Society guidelines are a little bit different, right? Because in the UK, though we tried to make fun of them a little bit, or at least I did, for their drinking habits as opposed to Americans and Canadians, it turns out that they well recognize something that we don't, and that we all live, whether we like it or not, in a resource-restricted world. Right? We don't have access to everything we want all the time. At least that's what I try to tell my kids over and over again. They don't always understand that either. And they complain a lot. So it turns out that the Brits well recognize that we can't guarantee access to annual or every 2-year colonoscopy in everybody. And based on minimal literature, they decided to risk stratify their IBD patients under surveillance, and they have a lower risk group that goes to every 5 years that you can see in that orange box there, which are patients who have really excellent levels of healing and have had a good prep and undergo their colonoscopy, and nothing's found. Those patients, they feel that we can wait every 5 years on, and then either go to every 3 years or every 1 year, depending on what we see. And what's interesting is that these guidelines came out around the same time as the ACG did incorporate chromo techniques into their guidelines. And so they're actually running the experiment on what may be the best kind of surveillance that we have, and how to best optimize surveillance, and what's safe and what isn't. And so we'll find out. I'm confident that our colleagues across the pond will go about analyzing these data and see how many breakthrough cancers that have arisen. So the British guidelines with pancolonic dye spraying and chromoendoscopy called for targeted biopsies of the abnormal areas, and then minimization of the random or non-targeted biopsies. You don't have to get to 33, right? And just doing, you can get to 16 if you just do 8 sections at 2 per. And it's not clear whether the biopsies will even stand up, and that's something we'll be able to analyze moving forward. I should point out that recommendation in the US, in the ACG, is based on some retrospective studies of patients who've undergone colectomy, and how many biopsies one needs to take to detect dysplasia when it's there. And to get to 90% confidence, that number has to be 33, or is 33. And that's based on some Seattle data. I have to throw the bone to the Seattle crew here. That's based on some Seattle data from the late 1980s. Haggett and Cy Rubin and those guys. So there are limitations to what we currently do, right? So first of all, and you guys got all this right, I'm not teaching you anything new, and I'm just reviewing this. There are no prospective studies that demonstrate a mortality benefit for surveillance, and not with chromo, and not with anything that we have. Interestingly, actually, the first surveillance colonoscopy in average risk patients just came out like a few weeks ago, where there was a cause-specific mortality benefit, at least in the AGA summary that gets thrown my way every morning. I came across that, which was good news. There are low rates of observer agreement in histopathologic interpretation of specimens. So what your expert pathologist calls low-grade dysplasia may not be the same as what my expert pathologist calls low-grade dysplasia. And when we get into community pathologists, it may even get a little lower, though there's been no well-designed study to demonstrate. But even among experts, and even at the time of clear definitions being performed in the early 1980s, there's always been this problem with observer agreement. The risk stratification hasn't really happened. It's been posited by the Brits, and we'll see what happens over time, but we don't really know. And there's been no adjustment over time for our improved technology, where we can see smaller and smaller and smaller things. And as the size and or complexity of what we see with our naked eyes at endoscopy gets smaller and smaller, so does the clinical significance of each one. Again, thinking about sporadic colorectal cancer, right? These sort of these diminutive polyps of less than 5 millimeters really aren't of much great clinical significance. There's an argument out there in the sporadic colorectal cancer world where I only dabble, and there's talk of, you can biopsy them and throw them away because all you're doing is adding to the pathologist's ability to put nice shoes on his or her children, but it's not adding anything to when to bring patients back in the sporadic polyp surveillance world. We're not there yet in IBD. I'm not sure they're there yet in sporadic colorectal cancer. So for now, when you do take out a small polyp, you can think of me, but you can put it in a bottle. But we're going to get there over time. We will get to the point of optical pathology at some point over time. We're getting close in sporadic colorectal cancer. The limitations of random biopsies, an easy dead horse to beat, though it's not quite dead. It's much more like the Monty Python, I'm not dead yet thing. We take biopsies, even at 33, we're really only sampling under 1/10% of the colorectal surface. So what the value of those is not clear, and I can tell you that the data for what are out there is really rather unimpressive. I can't remember if I have a table on it, but in the chromo studies that have been out there, the yield of non-targeted biopsies is always less than 1%. They certainly increase cost. They certainly increase time. They add little value, and they will eventually get to the dustbin of medical history. And this caused a little bit of controversy last time I mentioned this slide, so you can read it for yourselves. I won't say it out loud. So the vinegar ingestion for scurvy is a very interesting story, and when we're done or on a break, I'd be happy to share that one with you guys. So low yield, right? And here are some of those data. It's less, fewer than 1 in 500 non-targeted or random biopsies adds anything. It's just so small, and whether we do that on a per biopsy basis or even on a per patient basis, if you just divide that number by the 16 or 15 to 20 that an average colonoscopist will actually do in spite of the need for 33, that number still remains quite low. And then the random biopsies and chromo studies that I alluded to before, I couldn't remember if the table was still here, you can see it was really quite minimal, except in our study out of Mount Sinai, where it may have been as high as 10% on a per patient basis. But that's just not clear, and that was with substantially older endoscopic technique, even though it was published later than most, using mostly Olympus 100 and Olympus 120 scopes in those chromo studies from the mid-2000s. So it's important to recognize, and Brian has discussed issues of FDA requirements for diagnostic tests. Right? Not only is the bar different at the FDA, the bar is different in many of our journals that we do as well. And so to demonstrate that a diagnostic test is of value, you really have to compare it to some other form of a diagnostic test. And it's not like a treatment A, treatment B, where you're looking at an outcome measure like reduction in CDAI or mucosal healing, some effect on an outcome. You're actually measuring the output of that instrument, whatever that diagnostic test is. And it's just a fundamentally different kind of science that stands behind diagnostic test literature than stands behind randomized control or any other kind of cause and effect medical literature that's out there. And we always have to keep that in mind when we're thinking about diagnostic tests. So what does chromoendoscopy and spray dye do? it improves colonic visualization. And it's clear with older optics and standard def scopes, and to some extent in the more modern era as well, that it can improve and does improve the detail with which we see. But I hope I planted the seed in your heads that, that the detail may not quite be as important as we think it is. It may be good at finding smaller, irrelevant lesions, and that's all. Now, there are ways to twist the small and irrelevant lesions into being something of significance, and we'll get to that in a little bit. But keep that in the backs of your heads. This is how we do it. We have these little vials of methylene blue that about every 9 months or so become scarce in the U.S., and we race around. But when we have them, they're great. We take 20 mLs of that, or 2 of those 10 ml vials. We mix them in with 300 mLs of the water, and I'm sorry, I feel like I'm a prostitute for the Olympus company here. I have no relationship with them. We just happen to use the Olympus equipment where I was. Actually, where I am now, it's all Pentax equipment, so I've got to retool myself. So anyway, we mix it in the wash bottle with 300 mLs of water, and that makes a nice diluted solution of methylene blue. And then our foot pedal can deliver that dilute methylene blue to a well-prepared colon. And a well-prepared colon is the key to all that is colonoscopic accuracy. And so the thing that you're doing on your way in, when you're on your way to the cecum, is you are being probably a little more, or you should be when you're using this technique, a little more vigilant about cleaning out every last pocket of stool. Stool is the enemy in colonoscopy, and generally it is particularly the enemy in spray dye colonoscopy. And these are some results, or some pictures of some results that were in the literature that really got everybody worked up about this. In the upper panel, you can see the two arrows on the left pointing to a lesion that, with the use of a magnifying scope, and we don't need magnifying scopes when we do this, so you don't have to purchase new equipment if you want to do this. But you can see that lesion that you otherwise easily might have missed. And then scarier still, you see that lesion on the bottom panel that with white light scope looks like, that's just kind of burned out colitis. And then all of a sudden, boom, in really big three-dimensional relief that's there, you can see this very ugly looking lesion. This gets to the idea of resectability, you versus me. To me, that's not particularly resectable. To the more aggressive endoscopist in the audience, sure, you could take that out piecemeal. You wouldn't necessarily be sure that there was no underlying carcinoma, but you could do it. I'm not suggesting that you do. I wouldn't. And this is instructive in many ways. One, it tells us what we might have been missing all these years. But it turns out we haven't been missing much. I've been doing chromo for a while. I've never seen anything bloom like that. The other thing it tells us, and there is actually a literature on this by one of my former mentors, Alvin Feinstein, the so-called representative images that you see in the literature are not representative, okay? They never are. They're usually the single most illustrative examples to prove the point that the authors want to prove, and they'll just say it's representative. So always be careful and mindful of that, whether you're reading about blots, whether you're looking at endoscopic images. I'm sure the surgical literature is filled with this as well. It's just the nature of the way we do things. Small lesions, we do lift and cut, saline-assisted, or you can use chromo-assisted chromo with saline lifts as well to remove small lesions. And this is actually from one of my patients, and you can see that sort of bilobular lesion with less dye uptake in the left, sort of down in the center of that lesion picture. And then you can see the hamburger meat I turned it into by removing those 2 lesions. So prospective studies show that there's anywhere from a 1.5-fold to as high as a 5-fold increase in most of the studies that are out there. And that's using methylene blue. You can also use indigo carmine. It has slightly different properties in whether it's absorbed or just sits on the surface of the cells, and lets us see the difference in glands as well. And it's actually that difference in glandular architecture that tells us what we can and can't do and what it really looks like, and whether it's a pseudopolyp or not, or whether it's just a little bit of inflammation. There was this scenic group that Brian and I, among others, were part of. I thought it was a very wholly unsatisfying experience, except for the dinner. That was good. And it came up with these recommendations that chromo is preferable to white light, high def preferable to standard def, chromo with high def preferable to chromo with standard def, and you can read these down. And these had really almost dual publications, or excuse me, triple publications in a European journal, in ASGE's journal, gastrointestinal endoscopy, as well as in a GI, an AGA journal as well. I'm pretty sure it was in gastro, but it was a recommendation or a consensus recommendation, not a guideline in the AGA journal, and I think that that's important. And again, whether we were just picking up smaller stuff, all these recommendations were based on increased yield, nothing else, at least for the first 4. 5 and 6 are different, right? Remove it or send to colectomy. That's how we always do endoscopy. There were great limitations. There were no longitudinal studies analyzed as any part of scenic. We don't know the long-term benefits of this. There's a huge cost in training and equipment. And the fact that these were published some 3 years ago now, and the uptake has been very limited, tells me all I need to know, which is that I feel comfortable. And it turns out that we do just fine. In Mount Sinai, where I used to work, we had this wonderful publication. To me, it was wonderful. I don't have as many as Brian, so they're all wonderful. They're all my babies. And it turns out that the rate at which cancer is found following a negative scope within 2 years is to the tune of 1 in 1,000, which is pretty darn good. And that goes way back. That goes to even the fiber. Some of those scopes were even in the fiber optic era as well. So, we're chasing something that may not need chasing at this point in time. The important thing is to bring them in, bring them back regularly, and get really, really good looks. Do some form of biopsying. So the challenges to chromo, and I'm already over time, and I still have 2 slides, so I'm going to go quickly here, is that there's the perception that it's time-consuming and expensive. It is truly unclear if it changes any kind of outcomes, whether it's cancer incidence or cancer-related mortality, and certainly overall mortality. I don't think anyone posited that ever. Many patients don't qualify due to poor prep. Active inflammation hasn't been studied. It probably is the enemy of chromo, just the same way it's the enemy of regular surveillance scopes. There's no great consensus yet on its use in our field, and there's not a defined training pathway or competency requirement. That's something that's moving very rapidly as well in endoscopy in general. What we need are longitudinal studies and agreement on what the important ends worth achieving are. Is it dysplasia yield? I don't think so. Is it detection of cancers? I don't think so. Those are too rare, blessedly. Is it cancer mortality, morbidity? That would be nice, but that's going to be a huge challenge to ever figure out. But cost and intervals are really where the so-called money is. If a negative chromo exam is performed and you had a good prep, I believe we can start extending these intervals out beyond 2 years, 3 years, and so on. Brits are already running that experiment, as I mentioned, but we could do it as well to work alongside them. It would be nice to do better, but we're really already doing pretty well. The rate of cancer in colitis is declining over time, whether that's a function of our medications reducing inflammation or some anti-neoplastic properties that they have, whether it was oversold to begin with and never was as high as it had been published to be, or whether it's because we're doing these scopes in a better fashion. We're seeing a decreased incidence of cancer over time. We just can't line that up with our scopes just yet. And so is the curve changing? We used to think of this as a when and not an if proposition. And you can see on the left panel there that increasing incidence of cancer cumulative incidence of cancer over time with each passing decade, sharp increase in the rate that was happening in the slope of that curve. But you can actually see that blue curve that's down there from a publication we had in 2006. Can't believe it's still missing the date on there. Where our patients who had no dysplasia detected at their first Mount Sinai colonoscopy, very little ever happened to them over time. And so we're really, it's possible that we're overly vigilant, and that's fine, better overly vigilant than under vigilant, but it's possible that, that the value of each successive scope is decreasing over time with what we have. So how do you bring chromo into your practice? If you want to, get comfortable using the spray dye, fool around with it, use on small and medium-sized sporadic polyps so you get used to what the irregular glands look like with chromo. Understand the pit pattern classification that there was not nearly enough time to get into, but that's an important part, just understanding what neoplasia looks like versus a pseudopolyp versus normal tissue. And then start using it in your high-risk patients, and then if you want to, you can move on to all patients. I don't do that yet. I really only use it in my high-risk patients or highest-risk patients, and at some point you may want to consider stopping doing targeted biopsies if our societies ever let us get there. And I want to thank you, and I apologize for having gone over time. We'll get it back to you somehow, somewhere. Thanks.